thank you very much for that introduction. And also thank you to all the radiation oncologists for such a good workshop yesterday. I thought that was excellent. And thank you so much for the invite to talk. So I will be talking about how to optimize outcomes for locally advanced cervical cancer in the real world. And I mean, some of this, when we've been talking about what we talked about at the breakfast symposium earlier, feels very insignificant, but it does kind of feed on from that as well. So I'm the first person that can't do this. Which button do I press? Everyone else managed to do it.
And I'm terrible, so I'm not the right person to help you.
There we go. Okay. Okay, so these are my disclosures, but none of them are related to what I talk about today. So we all know that cervical cancer is a preventable disease. The problem is that you need access to vaccines and screening. And even in our experience so far, we're not seeing the numbers go down. There are more than 300,000 deaths per year from this disease. And 85 to 90% of these are in the low and middle income countries. And most people in the low and middle income countries do present with advanced metastatic or locally advanced disease. And we've seen some of these maps already today, but essentially where you can see the darker areas, you've got the highest incidence and highest mortality from this disease. So that's in your low and middle income countries. And there's another map following, which again we've seen already today from, with regards to radiotherapy that matches that, unfortunately. So chemoradiotherapy, doing good today, is the mainstay of this treatment, no matter what anyone else says. This is the curative treatment for locally advanced cervical cancer. And that is a combination of your external beam radiotherapy to treat the tumour and the pelvis, as well as brachytherapy to give the boost that gives a high enough dose to cure this, along with concurrent cisplatin. And this treatment works. So you can see on the left-hand side that there's a bulky tumour invading the upper part of the vagina. There's parametrial extension that you can't see on this image. But then 3 months after they have their chemoradiotherapy, it essentially looks normal. So this is a treatment that works. And what we class as the kind of gold standard approach is probably what people would say is the Embrace 2 approach. And this is something that has been a movement that has been for about 20 years. So this was started in 2005 when the gynae working group from GERCESTRO first published their guidance with regards to how to outline your target volumes for image-guided adaptive brachytherapy, and then they subsequently published their details on how to analyze the dose parameters, etc. And that has led to the Embrace 1 trial, which essentially adopted that image-guided adaptive brachytherapy and collected data of the outcomes of these patients, and it showed excellent local control rates. So you can see on the graph that nearly all the control rates, even for stage 3B disease, was in your late 80s or 90%, and quite good survival outcomes as well. So this doesn't take into account node positivity within this, but for example, your 2B patients, have got a 5-year overall survival of 78%. So this is really, it's good outcomes for these patients. And within that, the Embrace 2, what the ideal that we would all like to do to be able to treat these patients is image guidance. So ideally, you are imaging them daily with daily cone beam CTs, and that will allow you to facilitate smaller margins, and the use of intensity modulated radiotherapy, making sure you're not missing your target. Intensity modulated radiotherapy allows you to reduce toxicity and allows you to do boosts. So you can give boosts to your involved nodes and things like that, which you're not going to boost with your brachytherapy. And then we've already mentioned the MRI-guided adaptive brachytherapy. And so that's dose escalating your high-risk clinical target volume, which is basically tumour and cervix, and use of interstitial needles. And then overall treatment time is known to be a very important factor. So overall treatment time should be maintained at less than 50 days. And then your ideal is to be doing adaptive radiotherapy. So this is plan of the day, where you've got multiple plans you can pick from. That means that you're not irradiating too much bowel and bladder. Or, you can do online replanning. So every day you're kind of doing mini replans for the patients. And this is all fantastic. It's got good outcomes. However, this map shows you the availability of radiation therapy. And so the darker areas with the orange are areas where you've got no radiotherapy machines or less than one radiotherapy machine per million people. So again, this fits with those maps that we've seen before, which show your incidence and your mortality, and they don't have the radiation there. So, how do we deal with this? This is, a huge issue. And obviously, I don't have the answer to that today, but I've got little tweaks we can do. So the practical application of image-guided intensity modulator radiotherapy and image-guided adaptive brachytherapy, which is what we all would like to deliver, is very resource-intensive. Compliance is critical, so you've got to have patients that will comply, that can get to the treatments. There's significant issues with travel and practicalities if they've got, their radiation machine is 5 hours away or 3 days away. But there's also high cost, and that's high cost for healthcare, but it's also high cost to the patient. So that might be financial cost, but it's also social cost and obviously the healthcare cost. And here you've got that map again of the radiation therapy, but also the expenditure per capita with regards to how much the countries actually spend on their healthcare. And these maps are all looking so similar. It's all the same areas where they've got the issues. So what can we actually do to improve access or kind of improve the use of chemoradiotherapy? Is it possible? So, we've talked about radiation machine availability, but there's also brachy issues. There was a map this morning showing that, in Central Africa, there was no brachytherapy, 0, like for miles. And, could we use something, the external beam, to replace brachytherapy? Alternatives to MRI for your image-guided adaptive brachytherapy. So MRI is not that accessible, whereas ultrasound or CT might be more accessible. Can we shorten the treatment duration? So that's less burden on the treatment machines, less burden on the patients, etc. And essentially, we know that patients who cannot have brachytherapy for various reasons, we use external beam radiotherapy boosts. And that has been done for a long time, but historically, the dose that you would deliver with your external beam boost would be lower than with brachytherapy. And also, with brachytherapy, you don't need a margin between your clinical target volume, so the area that you want to treat, and what you plan to treat. And the reason for that is you've got your applicator in the middle of the target, so if your target moves, then the applicator moves with it. Whereas with external radiotherapy, if you've got movement with regards to uterus and everything, and you need a margin to account for that, and your daily setup error will be there and things. So you need some sort of margin, which means that overlaps with your organs at risk, so your bladder and your bowel that are around it. And also you don't get intense dose hotspots, and I'll explain a bit more about that. But use of intensity modulated radiotherapy, which is where you can sculpt the dose, so you can make concave shapes, etc., so you can spare your bladder, your bowel, your organs at risk, is useful because that allows you to boost your dose to higher, because it's generally the normal tissue that is limiting the dose that you're delivering. And so within comparable doses to your organs at risk, your bladder and your bowel, you can boost doses to a much higher dose, which is more comparable with your brachytherapy. However, even if you can't read the writing, the top lines are patients who receive brachytherapy, the bottom lines are the patients who do not receive brachytherapy. And these Kaplan-Meier's, you don't need to look at whether they're statistically significant. You can see from the back of the room that there is a big difference. So external beam radiotherapy boosts lead to inferior outcomes, and this has been repeatedly shown. So there's inferior overall survival, hazard ratio 1.86, 42% reduction in cancer-specific death, almost half your 5-year cancer-specific survival if you don't get your brachytherapy, if you have external beam boosts instead. SEER database, again, has confirmed that as well, so hazard ratios of 0.64, 0.66. So that is not acceptable. However, people could argue that neuroradiotherapy techniques allow you to focus your doses higher, and there are some small cohorts where people have shown relatively good outcomes with delivering doses to the same dose that you would prescribe for your brachytherapy with various new techniques such as stereotactic radiotherapy or stereotactic MR-guided radiotherapy. But on the images, what you can see, so the scan, which has got the big white applicator in the middle, is your brachytherapy, because that's the brachytherapy applicator. And what you can see on that is the red area is the 100% dose. And so that covers the area you want to treat. and then the scan beside it is your stereotactic boost. And again, the red area is covering what you want to treat. So your 100% dose is covering what you want to treat. The difference is you can't see a blue line with the external beam, whereas in the brachytherapy, you can see a blue line centrally, and that's 200% dose. So that's what I mean by the central high doses. So maybe that is what the difference is, and maybe that is why brachytherapy is much better with regards to outcomes. So brachytherapy should not be replaced with external beam boost. Obviously, if you cannot deliver brachytherapy, then that's a different discussion. But if you are going for cure, you need to be giving them brachytherapy, not external beam boosts. And newer technologies may be able to replace that, but further data is needed. However, realistically, those alternatives, if they do provide an equal outcome, they're going to be equally as complex and equally as expensive to deliver. So then, how can we sort of deliver our brachytherapy in a more accessible way? So, as I've already said, we use MRI as your standard for image-guided adaptive brachytherapy. And the question is whether you can use ultrasound. And a lot of centres will use transabdominal ultrasound for verification of positioning anyway. But here I'm presenting the Melbourne protocol, which is basically an approach where once you've put the applicator in, you create target points, which you ensure your dose is covering. So those target points you can assess on the ultrasound alone, and you are measuring 2 centimetres along the applicators, and then you measure the distance from the central intrauterine canal to where you want to treat, to the edge of your clinical target volume. And that's been correlated with MRI, and you basically prescribe your dose and you plan the dose to cover those target points so that you're essentially defining your outer limit, and that's what you plan to. And the outcomes for that have been shown to be good, and that has been replicated with other centres as well. So they've compared transabdominal ultrasound and CT and have shown that there's good outcomes. However, for ultrasound, you need people who can do the ultrasound, and also you need good views, and sometimes that can be quite tricky with regards to patients who've been having external beam radiotherapy. They've got lots of bowel gas, etc. It can be quite difficult to do, but if you've got experienced operators, that shouldn't be too much of an issue. Transrectal ultrasound is another approach which has been shown, and the Vienna group have published quite a bit on this. So transrectal ultrasound pre and post procedure can be helpful, but essentially there's some software that you can use that you can create a 3D image, and you can outline exactly as per the image-guided adaptive brachytherapy Gekestro guidance. And it's been shown to be more similar to MRI than CT, but there is some difficulties with small fields of view, so you don't necessarily get as good visualization of your organs at risk, of the normal tissues surrounding, and you can get some anatomical changes, so it sort of squashes the volume as such. But again, this is something that could be used. And then CT is something that historically a lot of centres use to look at your organs at risk, etc. And that can be helpful. It tends to overestimate your tumour volume, and it tends to overestimate the width compared to your MRI and ultrasound. So ultrasound is probably a bit kind of more similar to MRI. And there's been dosimetric studies, so looking at what doses you're delivering, and essentially it shows a slightly larger volume and perhaps a little bit of less dose coverage, but overall, when you compare it, it's probably much the same. And because it's been understood that MRI is not necessarily accessible everywhere, the Gekestro, ABS and IBS have all come together to do some contouring guidelines with regards to applying CT for this. Now, hyperfractionation is now focusing on the external beam radiotherapy. So this is something which essentially is shortening the duration of your radiotherapy. So most patients with cervical cancer will receive 5 weeks, so 25 fractions of treatment. And hypofractionation is where you deliver a higher dose per fraction over a reduced number of fractions. So you may give a typical one is 40 gray in 15 fractions, or on the lower image with the green, you've got 5 fractions given over a week and a half. And there was an Estro-Giro survey done, which showed that less than 10% of centres generally use this in all regions across the world. But in Africa, 32% of cervix cases are treated with hypofractionated regimes. And interestingly, the use of intensity modulated radiotherapy was one of the strongest predictors of the use of hypofractionation. And the reason for that is we actually tend to hyperfractionate people, so we often give them 1.8 gray per fraction rather than your 2 gray per fraction, which is what we kind of equate everything to, because that actually gives you a higher biological dose to your tumour preferentially over your organs at risk. So by giving a higher dose per fraction in every day, you're actually giving biologically more dose to your organs at risk that compared to tumour. And therefore you worry more about toxicity because you're biologically giving organs at risk, like your bladder and your bowel, higher dose. However, IMRT, it allows you to reduce your dose to your organs at risk, and therefore that kind of equates to balancing out that risk. The benefits obviously are reducing the resource, reducing the cost, reducing the patient cost. They don't have to travel as much. And also, I mentioned earlier that overall treatment time is important, and that's because of less repopulation of tumour. And so obviously you'd be significantly reducing your overall treatment time there. And there is some evidence to date. It's all retrospective, small phase 1-2 studies, and most of it is actually using old-style radiotherapy, so conformal radiotherapy, a very strange Brazilian regime where they have 2 fractions on week 1, week 3, week 5, and week 7, and you give the brachy in the middle. But these have shown reasonable treatment responses, and some toxicity levels, which some grade 3, 4 toxicities, but not horrendous, especially considering they were giving conformal radiotherapy, and one of them was just a 2-field and post-field, so literally just 1 field from the front and the back, so not very targeted. So that has meant that now there is quite a lot of interest in this. So there are quite a lot of phase 2 trials, all a little bit similar, but got their sort of subtle differences. In the Philippines, they've actually selected out patients who are not fit for cisplatin and higher risk, and they're doing a sort of dose escalation study looking at how much dose you can escalate your nodal boosts to. But most of these are using 15 fractions, so a 3-week course compared to a 5-week course, and around 40 gray in that 15 fractions. The Thailand and Canada trials are looking at quite a kind of range of patients, but not that high risk. And the main reason for that is that they've excluded patients that you would give para-aortic nodal radiotherapy to, because the concern there is that you're going to give much more bowel dose. And these things will read out relatively soon, but they've all got slightly different endpoints, but mostly toxicity and feasibility. So how can we improve access? What can we change? I think brachytherapy is key to optimal outcomes. Obviously, if there is absolutely no way to give brachytherapy, you can do external beam boost, but it's a survival difference in these patients. Transabdominal and transrectal ultrasound, as well as CT, can be used for your image-guided adaptive brachytherapy. And hypofractionation appears quite feasible and is under further evaluation. And I wouldn't be surprised if that moves forward. So then additional systemic therapy. So the next few slides I will be very quick because there are people in this room that know a lot more about it than I do. But I'll talk about adjuvant therapy and then neoadjuvant and immunotherapy. So adjuvant chemotherapy, so the Outback trial was obviously a very large randomized controlled trial comparing chemoradiotherapy versus chemoradiotherapy and 4 cycles of carboplatin and paclitaxel, with over 900 patients recruited, and the primary endpoint was 5-year overall survival, which there was no difference according to this trial. And so on the forest plot, everything is overlapping with 1 here, so there was no clear subgroups as to who benefited. So the conclusion from Outback, looking at adjuvant chemotherapy, is that there's no survival benefit, and therefore this should not be used in this setting. Moving on to neoadjuvant chemotherapy, quite a lot of us had quite a lot of discussion yesterday regarding this. This is the Interlace trial. So this is looking at chemoradiotherapy versus chemoradiotherapy plus induction chemotherapy, which is 6 weeks of carboplatin and paclitaxel followed immediately by the same chemoradiotherapy. And this was set up sort of similar time to sort of Outback, and therefore the inclusion criteria is similar. So patients with lower vagina involvement and paraortic nodes were not included in this study. And this had a primary endpoint of progression-free survival and overall survival, and lots of stratification factors. So within this trial, most patients were stage 2, most patients were squamous, about 80% or so, which is representative of usual practice, and just over 40% were node positive. And that has shown an improvement in progression-free survival with a hazard ratio of 0.65, so a 35% reduction in the risk of progression, and a 9% improvement in your 5-year progression-free survival from 64 to 73%. And similarly, with overall survival, there's an 8% improvement from 72% to 80% at 5 years, with a hazard ratio of 0.61. So that's a statistically and clinically significant improvement in survival, and that's the first improvement that there has been in more than 20 years in this cohort of patients. With regards to subgroups, this hasn't really kind of given us any more information. And interestingly, it doesn't seem clear that it's your highly node-positive patients that get more benefit, but every group seems to get benefit. With regards to adverse events, there's an increase in adverse events, which is what one would expect, and about a 10% increase in your grade 3-4 adverse events. So the interlace conclusion is that the induction chemotherapy prior to chemoradiotherapy leads to a 9% improvement in progression-free survival and an 8% improvement in overall survival at 5 years. And therefore, induction chemotherapy with carboplatin prior to chemoradiotherapy should be considered as a new standard of care, and importantly is feasible across diverse healthcare settings, but should not be used as a replacement for delays in radiotherapy. And then moving on to the last one, which is immunotherapy. So Keynote A18 was a much higher risk group compared to the interlace group. So these were stage 3-4 patients or node positive 1-2. And they were randomized to receive Pembro concurrently with chemoradiotherapy and then adjuvant for 2 years, or chemoradiotherapy alone. And they, as I said, it's a much higher risk group, so it was about 17% of patients did not have any nodal involvement. They had more patients treated with IMRT, but 9% of patients had a planned dose of less than 70 gray, which is not curative dose. So they've shown a statistically significant improvement in progression-free survival, and at 2 years, there's about a 10% difference. But more than half of the patients are still on treatment, and the median follow-up is 17.9 months. So, it is statistically significant with a hazard ratio of 0.7, so a 30% reduction in risk of progression. But it's quite immature data, and there are a lot of patients still on treatment. And then overall survival has not shown a statistically significant improvement, but one can argue that there's a trend. But again, with such a high proportion of patients still on treatment, it's difficult to conclude from this. Their forest plot, again, shows that nearly all subgroups have improvement, but the reason that the FDA have gone with approval for stage 3-4 is because you can see there that the hazard ratio is 0.58 for the stage 3-4 patients, and is much closer to 1, being 0.91 for your 1B, stage 1-2 node positive patients. And I think treatment-related AEs, again, it's higher because you're getting more treatment, but nothing that was particularly unexpected. And obviously, immune-mediated AEs were there. So the Keynote A18 conclusions are that pembrolizumab provided statistically significant and clinically meaningful improvements in progression-free survival, and there was benefit across all subgroups. High-quality radiotherapy delivery was ensured, and therefore they would say that pembrolizumab plus chemoradiotherapy is a new potential standard of care for patients with newly diagnosed high-risk locally advanced cervical cancer. So with regards to systemic therapy, from the data we've got so far, we say adjuvant chemotherapy does not improve survival. Induction chemotherapy does improve survival, but it's unclear at this point which subgroups benefit more. Hopefully we will get more details on that. Pembrolizumab may have a role in high-risk cases, so there's an improvement in your progression-free survival, but it's quite immature data at the moment. But thinking about what I've talked about already, there's potential of hypofractionation, etc. We do have to consider how the increase in toxicity would work with hypofractionation, if that's something that comes through. And also, how realistic is it to deliver additional therapy for such prolonged durations? Firstly, it's the healthcare cost, but also compliance of patients. Once you've told them that they've got no visible cancer, it's very difficult for them to then turn up for treatment for 2 years. Half of my patients won't even come for follow-up. How can we actually apply that? So moving forward, I think one of the biggest things is obviously having meetings like this and actually recognising that variation in care and the variation in access to care and what we can do together to work through that, and improvements in collaborative working. And I think it was mentioned earlier, improvements in education, and that's education of healthcare professionals, education of patients, and training. Collaboration with industry, I think, is important because they need to understand what we know the issues are. Otherwise, they chase things that are not important. And then, ongoing trials and investment in things like use of ultrasound. It's not attractive. It's not, lots of money in it, but it's important to chase these things. And hypofractionation could go somewhere. And then feasible incorporation of systemic therapy. Should we be thinking about immunotherapy for shorter durations or combining your induction chemotherapy and immunotherapy? So quality radiotherapy remains the mainstay of treatment for these patients. Brachytherapy is essential, but you can use ultrasound or CT if you've got limited MRI access. And hypofractionation may be something that's coming through to shorten duration and make treatment more accessible, free up treatment machines, etc. Induction chemotherapy improves survival and is feasible in all healthcare settings, but as I said earlier, must not be used to replace delays in radiotherapy. And the role of immunotherapy is exciting and will have a role in high-risk patients, but how we can interpret that at the moment is difficult to say. Thank you very much for listening.